My name is Vicky Tagalakis. I'm Division Director of General Internal Medicine at McGill University, Montreal, Canada, and I am a thrombosis physician specialist. I specialize in the treatment and management of thrombotic disorders. Case study: Anticoagulation in Metastatic Colorectal Cancer. Mrs. R.S. is a 54-year-old high school teacher. She's married with a mother of 2 adult children. Her past medical history is significant for hypertension and hypercholesterolemia. Both are well controlled with appropriate medications. Her body mass index is 31. Her CBC, electrolyte, urea, creatinine, and liver function tests are all within normal limits. Ms. RS is diagnosed with colon cancer, and she undergoes a left hemicolectomy and colostomy. Surgery lasts for about an hour. During the surgery, peritoneal metastases are found. Following surgery, she is admitted to the ward, and low molecular weight heparin prophylaxis is started. She is discharged 10 days later. The question is, do you continue thromboprophylaxis after discharge? What is the prolonged risk of venous thromboembolism in the post-operative period? Abdominal surgery leads to a hypercoagulable state and is associated with increased thromboembolic risk that lasts at least 14 days. According to several prospective cohort studies, the incidence of post-operative deep vein thrombosis is as high as 25% in the 4 to 6 weeks after general surgery, while the incidence of pulmonary embolism following surgery ranges from 0.13 to 0.63%. The incidence of venous thromboembolism following general surgery in patients with cancer is estimated to be twice as high as patients without cancer. Cancer patients have higher rates of postoperative venous thromboembolism, pulmonary embolism, fatal pulmonary embolism, and death compared to non-cancer patients despite thromboprophylaxis. At the Ristos time distribution of VTE events trial, we note that 81.6% of patients received in-hospital prophylaxis and 30.7% received post-discharge prophylaxis. 50 of the 2,373 patients, or 2.1%, developed venous thromboembolism following surgery. What's interesting was that 40% of the VT events occurred more than 21 days after surgery. And so there have been extended prophylaxis studies with low molecular weight heparin following cancer surgery, which have been shown to show efficacy vis-a-vis prevention of venous thromboembolism. And we have studies involving the enoxaparin or the enoxacan-2 study, dalteparin, the FAME study, and Canbisher, the bemiparin study, all comparing to placebo versus no therapy following discharge from hospital and extending prophylaxis as a result. And as you can see, venous thromboembolism was reduced with extension of low molecular weight heparin prophylaxis with non-significant increase or non-significant differences in major bleeding compared to the placebo or no therapy arm. And specifically, extended prophylaxis in patients with cancer undergoing surgery has been looked at. It's been looked at specifically in patients with abdominal or pelvic surgery for cancer. Low molecular weight heparin for 7 days was compared to low molecular weight heparin for 28 days. And the endpoints in all these studies were routine bilateral venography at 28 days, as well as symptomatic VTE. And as you can see here, we have the enoxacan-2 that used enoxaparin versus placebo and tested the 7 versus 28 days, and the FAME study, which used dalteparin versus no prophylaxis. And what we mean in the comparator of placebo versus no prophylaxis is that all the patients in both arms got 7 days of low molecular weight heparin, but the enoxaparin or the dalteparin group got an extended therapy up to 28 days, whereas the comparator arm got a placebo or actually got no prophylaxis. And we see that the rates of VTE are a lot less with the extended low molecular weight heparin therapy. And And here we have a meta-analysis that was done of these various studies showing that the incidence of any venous thromboembolism following in patients undergoing abdominal pelvic surgery for cancer, the rate was significantly reduced with extended thromboprophylaxis compared to conventional thromboprophylaxis with a risk ratio of 0.44. And when we look at major bleeding, in the same meta-analysis, there was no significant impact on major bleeding when looking at thromboprophylaxis extension. So if we look back at Mrs. RS, remember at surgery, Mrs. RS was found to have peritoneal metastases. So she started on chemotherapy in a stop-and-go fashion for 2 years. She presents with painful, swollen, and red lower left limb. Ultrasound confirms a proximal DVT of the left popliteal vein. What would you do next? How would you treat Mrs. RS, and why do you choose this option? Your options are listed there from A to F. Moreover, what if Mrs. RS renal function is decreased with a creatinine clearance of 29 mils per minute following surgery? This is a foreseeable possible complication or development with chemotherapy. And so would this influence what you choose in treating Mrs. RS's new thrombotic episode? Vis-a-vis renal dysfunction and anticoagulation, it is clear that renal function surveillance should be exercised in patients with creatinine clearances less than 50 mils per minute. Therapeutic doses of low molecular weight heparin should be avoided in cases of severe renal disease with creatinine clearances less than 30 mils per minute unless monitored by an anti-factor Xa heparin levels. Low molecular weight heparin should be used with extreme care in patients with end-stage renal disease requiring dialysis. We've looked at low molecular weight heparin in patients with cancer-associated thrombosis and renal insufficiency. And in general, when we look at patients specifically from 2 different studies, the CLOT study and the CATCH study, both are studies that looked at the treatment of venous thromboembolism and cancer-associated thrombosis. The CLOT study used dalteparin, and the CATCH study used dinzaparin. And when they did subgroup analyses for patients with reduced renal function, specifically in the CLOT study, they looked at creatinine clearances less than 60 mils per minute, and in the CATCH study, they looked at patients with creatinine clearances between 20 and 59 mils per minute. Granted, there were small numbers in both studies. However, the authors noted that there was no statistically significant difference vis-a-vis events, vis-a-vis patients for venous thromboembolic events of recurrence, nor was there any statistical difference vis-a-vis major bleeding when looking at these subpopulations of patients with cancer-associated thrombosis and renal insufficiency, suggesting that using low molecular weight heparin for treatment of venous thromboembolism in patients at this degree of renal dysfunction is likely relatively safe and efficacious. Back to our case, what if Ms. RS was receiving adjuvant FOLFOX chemotherapy and her platelets were chronically in the 75 to 80 range? How would you proceed? And your options A to F are listed there. We pause now for your selection. Anticoagulation and thrombocytopenia is an important aspect of the management of cancer-associated thrombosis, since patients undergoing chemotherapy are at high risk for thrombocytopenia. First, when dealing with this presentation, one should ensure that heparin-induced thrombocytopenia is excluded, which can happen with anticoagulant therapy, and so that needs to be considered. Then the risk-benefit balance of anticoagulation should be reassessed in the presence of thrombocytopenia. Thrombocytopenia increases one's risk of bleeding, and one needs to reevaluate this whenever it develops in a cancer patient who is being treated with an anticoagulant. The risk of VT recurrence is particularly high in the first 3 months after thrombosis, and so generally the option would be to try to continue anticoagulant therapy during this time period. Thereafter, the risk of recurrence is somewhat less, and where there is some leeway to consider holding anticoagulation in these patients after the 3 months. Full anticoagulation, either with a direct oral anticoagulant or low molecular weight heparin, does not pose excessive risk when platelet counts remain above 50 times 10 to the 9th per liter. So generally speaking, with platelet counts above 50, full anticoagulation should be administered in patients with an acute venous thromboembolic event. Here we show the algorithm for the management of patients with thrombocytopenia, specifically platelet counts less than 50, in a patient with an acute venous thromboembolic event, and by acute we've defined it less than 1 month following diagnosis. So if a platelet counts drop to below 50 in a patient who's had a PE or a DVT diagnosed within the month, then the option for management is defined as such, where we want to be able to, as much as possible, maintain full dose anticoagulation, as this is a critical time where the risk of embolization and progression are the highest, and to be able to maintain therapeutic anticoagulation, a recommendation has been made to proceed with platelet transfusions to be able to support therapeutic doses. If one is unable to maintain platelets above 50 with platelet transfusions, or it's not feasible to access frequent platelet transfusions, then the recommendation is that if the platelet count is between 20 to 50, then dose reduction by 50% is recommended. And if the platelet count is less than 20, then the recommendation is to hold low molecular weight heparin, and obviously to consider an IVC filter for these patients, given that the risk of embolization is quite high during this period of time. If we're looking at thrombocytopenia in patients with an acute venous thromboembolism, so patients with cancer and acute clot, and now we're past the initial 1 month treatment, then the ISTH subcommittee suggests reducing the dose of low molecular weight heparin to 50% of the therapeutic dose, or using a prophylactic dose of low molecular weight heparin in patients with a platelet count between 20 and 50. So there is no need at this time to maintain platelet transfusions or to maintain a full therapeutic dose of low molecular weight heparin because we are past that critical first month. They do suggest discontinuing anticoagulation in patients with platelet counts of less than 20. In conclusion, patients with cancer-associated thrombosis who are managed with low molecular weight heparin due to renal dysfunction or low platelet counts can be complex and require very close follow-up, and management is based on determining risk of recurrence versus risk of major bleeding and balancing these two during the course of therapy.